So thank you all for coming today to our Tennessee Center for AIDS Research monthly seminar series. I'm John Curta, the director of the Center for AIDS Research, and today I'm absolutely delighted to welcome one of our CFAR members, Dr. Qasim Borji, who will be presenting our seminar, ART-Associated Weight Gain Perspectives from Regional, National, and Global HIV Cohorts. And Dr. Borgi has really been a leader in this field for decades. Well, I should say for a decade. He has led several of the seminal studies, going all the way back to 2016, 2017 on weight gain and antiretroviral therapy. But this is only one part of a much broader career as a leader in clinical trials, um, prevention clinical trials, treatment clinical trials, as well as mental health disorders and long-term use of antiretroviral therapy. Dr. Borgi got his medical degree from American University in Beirut, and this was then followed by a residency at Wayne State University. He then came down to Nashville to the Vanderbilt Division of Infectious Diseases, where he completed his fellowship in infectious diseases and did much of his initial research in this area before moving to Indiana University. And we were then delighted to recruit him back about a year and a half ago as the medical director of Nashville Cares, as well as the Cares 360 Community Clinic. And Nashville Cares is one of the 4 partner organizations of the Tennessee CFAR. And for those maybe from outside of Tennessee, it's one of the oldest, largest, and most sophisticated HIV community-based organizations in the U.S. In addition to his role as medical director at CARES, Dr. Borgi is also an assistant professor of clinical medicine at Vanderbilt University Medical Center. So Qasim, thanks again for coming to talk to us today, and we're excited for your presentation.
Good afternoon, everyone, and thank you so much, John, for having me on this talk. So as John mentioned, I'll be talking about ART-associated weight gain, and I've been working on this topic for the last 10 years, and it actually started under the mentorship of John back in 2016. Starting with some disclosures, I serve as a consultant and receive research support from Gilead Sciences. I'm also a consultant for both Merck and ViiV Healthcare. None of those should intervene with the content that will be presented. Some of the objectives for our talk today. So initially, I would like to spend some time summarizing findings from regional, national, and global cohort studies that have been led by our group examining ART-associated weight gain. I'd like to explain how those analyses of very heterogeneous and very different cohorts have contributed to the current understanding of the role of INSTIs, the role of TAF, and efavirenz TDF in weight trajectories. And then finish up by discussing the clinical and public health implication of our ART-associated weight gain, especially when it comes to high-risk populations. So giving a little bit of a background, the prevalence of obesity has drastically increased in persons living with HIV. In this day and age, more than 50% of persons living with HIV in the US are either overweight or obese. And the reason behind that is multifactorial. There are some off-target effects of antiretroviral therapy, but also the social determinants of health, psychological factors, mental health factors, all contribute to this high prevalence of obesity. We also know that starting ART for all patients, even for patients who do not have a very low CD4 count or not starting with AIDS, the ART initiation is associated with significant weight gain. Now, the extent of weight gain varies depending on certain clinical factors, and we know certain patients who have very low CD4 count and profound depletion in their CD4 count or low BMI tend to be the ones that have this return to health phenomenon and therefore the highest amount of weight gain following ART start. But we also know that people who are relatively healthier at the time of ART initiation also do experience significant weight gain. And clinical studies have shown us that this ART-associated weight gain is not benign. It's associated with increased rates of obesity, cardiovascular disease, and other metabolic complications. So in 2014, the FDA approved dolutegravir-based ART, and it was at that time where the uptake of integrase-based regimen had significantly increased in the US. And it was around that time with a fixed combination of dolutegravir, abacavir, 3TC, or Triumeq that a lot of clinicians started switching patients off of efavirenz-based therapy. Early on, clinicians observed that there's some unexpected weight gain that's happening in those patients who are going from Atripla to Triumeq. And the concern was whether those integrase inhibitors, and particularly dolutegravir, was contributing to this excess weight gain. So this was around 2016, and I was a first-year fellow at Vanderbilt when when John's team actually published one of the very early studies looking at this. So this was in Jade's 2017, looking at retrospective analysis of almost 500 patients at the CCC in Nashville. And the primary objective was looking at the weight change in patients who remained on Atripla versus those who switched to integrase inhibitors at the Vanderbilt cohort, with the secondary objective at looking at differences between the different integrase regimens. So those results were really striking. Compared to those who continued on Atripla, who had by the 18-month 0.9 kilogram weight gain, those who switched to integrase inhibitor had significantly higher weight gain of 2.9 kilos. When it was broken down by individual integrase inhibitors, it looked like the weight gain with dolutegravir, abacavir, 3TC was also significantly higher than valtegravir and elvitegravir. So it was around this time when I got really interested in this topic and hope to expand more on those studies and try to really learn what's going on with this weight gain with integrase inhibitors and whether those drugs themselves were contributing to that weight gain. So in one of the very early studies that I published on this in CID in 2019, we looked again at the CCC cohort, but looking at treatment-naive individuals. So we had around 1,100 treatment-naive patients starting ART over the span of 10 years and looking at integrase-based regimen versus PI versus NNRTI with a follow-up of 18 months. So this result showed, again, a striking difference in the weight gain, and those are treatment-naive individuals by what treatment they're starting. So you can see in the red line, the dolutegravir patients had the highest amount of weight gain compared to the elvitegravir with the lowest amount of weight gain. Also in this study, we noticed that the weight gain with integrase inhibitor appears to be with dolutegravir in particular, appears to be statistically significantly higher than NNRTI and PI-based regimens. So the highest weight gain was with dolutegravir of 6 kilos compared to NNRTI of 2.6 kilos. And so by this time, from the Vanderbilt cohort, we had two different studies. One study in a treatment-naive individual, in a treatment-experienced individual, showing that switching to an integrase-based regimen is associated from efavirenz is associated with significant weight gain, and another one in the naive cohort that's showing that integrase-based regimens are associated with significantly higher weight gain than traditional NNRTI-based regimens. I also worked with Dr. Haas's team and at looking at this exact same cohort at patients who were suppressed on Atripla, on efavirenz, and switched to integrase inhibitors, looking at the role of the CYP2B6 polymorphisms, basically polymorphisms in efavirenz metabolism, and whether this affected weight gain at all. So again, we're still in the Vanderbilt cohort, and what we found in this study is that those who are slow metabolizers of efavirenz, prior to switching to integrase inhibitors, at the time of switch had the highest amount of weight gain. Compared to the normal metabolizers, and therefore they have normal level of efavirenz pre-switch, had lowest amount of weight gain after switching to integrase inhibitor. So really what this study showed is that efavirenz and the level of efavirenz pre-switch played a key role in determining how much weight are patients going to gain after switching to an integrase inhibitor. So the 2b6 genotypes that predicted higher efavirenz concentration pre-switch were associated with greater weight gain. And this supported the idea that efavirenz is a weight suppressive drug and raised the question about whether a lot of what we're seeing is mostly driven by efavirenz being weight suppressive, or is it that those integrase inhibitors are weight promoting? So this was the background for the very first NA Accord weight analysis study that we did back in 2019, and had really significant results in CROI of 2019, looking at 19 cohorts across the US, Canada, and Puerto Rico, spanning different regions of the US with more than 7 million patient month observations. So those were all naive individuals starting ART over the span of 10 years, comparing integrase inhibitors to traditional NNRTI and PI-based regimen. And we wanted to see whether, similar to the Vanderbilt cohort, is there any difference between integrase inhibitors and NNRTI and PI? And also among the integrase inhibitors, are there any differences between the INSTI core drugs? We had 22,000 individuals in this study, 19 cohorts in US and Canada over 10 years, and the results were really striking. By year one, you can see the red line are the integrase-based regimen, the blue lines are the PI-based regimen, and the NNRTIs are shown in green. So you can see by year 5, a significantly higher weight gain with integrase inhibitors compared to NNRTI. Namely, it's a difference of 6.1 kilos with INSTI versus 4.1 kilo with NNRTI. Now, in this study, again, because the end date of the study was in 2016, very few patients were on TAF-based regimen, and we really did not account for what background and NRTI backbone were those patients on. But just looking at this first graph, one would deduce that there's really a significant difference in between ART classes and the amount of weight that is gained. Now, when we broke it down by individual integrase inhibitor core drugs, similar to the Vanderbilt cohort, it appeared that the elvitegravir had the lowest amount of weight gain compared to dolutegravir and valtegravir. So this was the second study that is showing that there's a really discrepant amount of weight gain, even among the integrase resistant, integrase drugs themselves. So for example, in the first graph, looking at dolutegravir, so all the INSTIs are in red, PI in blue, and NNRTI in green. And what's changing between those graphs are the actual INSTI core drugs. So you see that with valtegravir and dolutegravir, the weight gain is significantly higher than that with NNRTI. But that's not the case with elvitegravir. And that raised the question about whether it is something particular about elvitegravir itself that's resulting in lower amount of weight gain with this drug. But also it's worth noting that elvitegravir is the only integrase inhibitor that's co-formulated with a booster, cobicistat, and therefore whether what we're seeing in differences between those integrase inhibitors could all come down to the to differences in the effects of the booster. Also, as I mentioned initially, that we have the proportion of HIV patients in the US who are overweight and obese is drastically increasing with time. And you look here in the 22,000 patients over the in the NA Accord, you see that more than 50% at the time of ART initiation were either overweight and obese. Now, looking at those who start here with a normal weight, almost a third, more than a third of those patients transition over a 3-year period to become overweight or obese. So this amount of weight, this difference in weight gain is really translating in differences in the rates of obesity. And with the overweight and by year 3, you notice that the minority of patients now have a normal weight, and more than 2/3 of the patients are either obese or overweight. But also what we noticed in this study is that the weight gain is not uniform. There are certain patients who are gaining significantly more weight than others, and there are certain predictors that would predict this extreme weight gain. So for example, in this graph, you can see that at 2 years and 5 years, integrase inhibitors and PIs are significantly more likely to be associated with extreme weight gain compared to NNRTI. And the way extreme weight gain was defined as having a weight gain of more than 10% compared to baseline. Also, older age, higher baseline weight was associated with lower weight gain. Lower baseline CD4 count was associated with significantly higher amount of weight gain compared to higher CD4 count. And when looking at integrase INSTI medications, elvitegravir was associated with significantly lower risk of extreme weight gain. So this was the first study from NA Accord that again really reiterated the results from the Vanderbilt cohort, showing that there's a significantly higher weight gain with integrase inhibitors, that even among integrase inhibitors, there's differences between the weight gain by the component INSTI drugs, and also showing the clinical implications of this weight gain on the prevalence of obesity. Now, I should note before moving that remind everyone that this study did not account for what's the backbone and an NRTI that's used, and also that this study included patients who started medications between 2007 and 2016. Therefore, a lot of the newer integrase inhibitor regimens were not included in that analysis. By this time, it was 2020, I had moved to Indianapolis, and Indiana University, they are the leaders in the AMPATH group, another AD cohort that is based in East Africa, and they do phenomenal work with biostatistics studies as well as clinical studies out of East Africa. And I got really interested in trying to answer this question in the AMPATH cohort and to see whether a similar phenomenon is happening in East Africa compared to the US. So why should it be any different? Why should patients in Africa be different than what we're seeing in the US? Well, most of the studies that we've had by that time were based in the US, where baseline BMI is either normal or high. Women are a minority of patients living with HIV, and HIV-TB co-infection is much less common. Compare that to sub-Saharan Africa, where the majority of persons living with HIV are women. Patients often present with much more advanced AIDS and HIV, including lower CD4 count and lower baseline BMI, two factors that are strongly associated with increased risk of extreme weight gain. Additionally, in sub-Saharan Africa, TB co-infection is very high, and food insecurity are quite prevalent. Those are two factors that play a key role in weight gain following ART initiation. Around that time, also, there was a large-scale rollout of dolutegravir within sub-Saharan Africa, and what was happening is a lot of those governments were changing the HIV treatment guidelines. So for treatment-naive patients, dolutegravir became the drug of choice, and a lot of treatment-experienced patients were being switched off of efavirenz-based therapy to dolutegravir-based therapy. Now, almost all of those patients who were either started or switched to dolutegravir were on a TLD regimen, dolutegravir that's co-formulated with tenofovir disoproxil and lamivudine. So in the naive cohort, I really wanted to answer whether dolutegravir drives similar amount of weight gain among treatment-naive individuals in Africa the same way it does in the US. So in this study, we had over 17,000 treatment-naive individuals. You can see the difference in AMPATH, we had 22,000 over a 10-year period compared to a region in East Africa where we had 17,000 over a 2-year period. The vast majority, 97%, were on an NNRTI-based regimen. 3% were on dolutegravir-based regimen. Again, compared to the US, the majority were women, 62% females, median age of 36, and 6% of the patients were co-infected with tuberculosis. Clinical characteristics, those patients were quite sicker than the US patients. They had a much lower median baseline weight of 58 compared to an accord of around 70. Their median BMI was 20.8, again, compared to the US, where the median BMI is 25. Around 1/5 of the patients were underweight. And also the median baseline CD4 count was 298, with around 12% having a CD4 count less than 200. So sick patients with high prevalence of AIDS. Looking at the changes in weight by ART class and sex. So in this study, the red lines are for dolutegravir, blue are for NNRTI, solid lines represent males, and dashed lines represent females. Obviously, for females, the initial weight, they start from a lower weight compared to males. However, they do catch up, particularly for the dolutegravir, those who are on dolutegravir. And by 18 months, you can see that women on dolutegravir gained 6.1 kilos compared to 2.6 kilos for women on NNRTI. Men on dolutegravir gained 4.1 kilos by 18 months compared to 2.8 kilos for men on NNRTI. So really what this study had showed us that both ART class and sex are two very important factors in determining how much weight is going to be gained by 18 months in East Africa, with the higher weight gain with dolutegravir compared to NNRTI. And this is particularly true among women who experience the highest amount of weight gain, with a median weight gain of 6.1 kilos in a year and a half. We said around 6% of those patients were co-infected with tuberculosis. With HIV, there's a return to health phenomenon for patients, especially patients who have advanced HIV. There's also a return to health phenomenon when TB patients are started on TB treatment. So we looked at whether TB co-infection played any role in how much weight is gained. You can see at the start of ART, at the time of ART initiation, those who were TB co-infected had a significantly lower baseline weight compared to those who were not on TB treatment. And the reason those are labeled TB co-infected and not on TB treatment is because in empath, the best way to know whether someone had tuberculosis is whether they were initiated on a tuberculosis treatment at the time of ART initiation. So the ending weight was similar, but when we look at how much weight was gained, those who were not on TB treatment, and therefore we assume they were not TB co-infected, had around 3.5 kilos of weight gain, where patients who were TB co-infected had more than 9 kilos of weight gain by 18 months. So again, a key difference compared to the US population, especially with this relatively prevalent comorbidity. Looking at predictors of extreme weight gain in this cohort, we found that, again, compared to females with NNRTI, the females who are started on dolutegravir had a significantly higher risk of experiencing extreme weight gain. Again, those who were underweight at baseline had much higher risk of having extreme weight gain, while those who were overweight or obese had significantly lower risk of extreme weight gain. And similar to the cohorts from North America, we found that lower baseline CD4 count was associated with extreme weight gain. While, finally, as I mentioned in the earlier slide, that TB treatment was also associated with extreme weight gain. So at that point, we had evidence from East Africa supporting very similar findings to evidence from North America. Looks like integrase inhibitors are associated with significant amount of weight gain. Looks like there are certain groups of individuals who are at a much higher risk of gaining weight compared to other groups, particularly among females. However, as I mentioned, that with the rollout of dolutegravir in East Africa, it was also rolled out as a switch regimen. And patients were switched to dolutegravir tenofovir disoproxil, and lamivudine. The question was whether the pre-switch regimen really matters. So what I mean by this, in the US, most of the patients who were on NNRTI were on efavirenz TDF-based regimen. This was not the case in Africa. Around half of the patients were on nevirapine-based regimen. So what is happening to those who are switching off of nevirapine to dolutegravir? Are they gaining same amount of weight as those who are switching off of efavirenz? Especially that we know that efavirenz is weight suppressive. So prior US and ACTG data had suggested that there's some weight rebound when you switch off of efavirenz, but we really did not know whether this extended to other NNRTI. Is it the same for nevirapine? So the question we wanted to answer is, does the weight gain after switching to TLD differ by, one, the pre-switch NNRTI, whether it's efavirenz or nevirapine, and two, whether it differs by the NNRTI, whether it's AZT or TDF? So this is why I did the switch analysis in AMPATH, and included in this analysis 18,000 virally suppressed patients. All of those switched to TLD. Almost half switched from efavirenz, the other half switched from nevirapine. More than half of the patients were females, median age 51 year, median BMI of 22, and a pre-switch CD4 count of 175. The NRTI backbone was most commonly TDF3TC for those who are switching from efavirenz, but it was AZT3TC from those switching from nevirapine. Those were another oral presentation at CROI in 2023, and the results were really significant because as you look at in the graph, the blue line is for nevirapine, red line is for efavirenz, and you can see on the x-axis, the middle point is the time zero. So what we intended to look at is compare the rate of weight gain pre-switch to post-switch. Starting with efavirenz, you can see patients gain weight regardless. But there is a significant increase in the rate of weight gain at the time of switch at time zero. So for efavirenz, they were gaining around 0.5 kilos per year, and then after they switched, they gained 1.1 kilo per year. So this tells you that something happened, that this switch phenomenon is contributing to this significantly higher rate of weight gain. But similar phenomenon was not seen with nevirapine. With nevirapine, the rate of weight gain really did not change at the time of the switch. So if we think that dolutegravir is weight promoting, is causing weight gain, you would imagine that whatever a patient switches from, they should have a significantly higher rate of weight gain following the switch. But this study did not show that. Rather, it highlighted that maybe the biggest contributor to this higher rate of weight gain following the switch is really we're stopping the inhibitory effects of efavirenz on weight gain. As I mentioned in the previous slide, the NRTI backbones were similar. So the question is, well, what if we accounted for the NNRTI backbone? And what we found is very similar results. Now, maybe a little bit higher weight gain for those switching from nevirapine and TDF compared to nevirapine and no TDF. But the biggest determining factor was still, what is the NNRTI pre-switch? So the greatest weight gain was seen with efavirenz TDF3TC, and the lowest weight gain was seen with nevirapine AZT3TC. Therefore, what this study had showed that both the pre-switch regimen, the NRTI backbone, as well as the NNRTI drug, are both playing a key role in determining how much weight is gained following the switch. And really, this study put into question whether really is dolutegravir really weight promoting, and why are we seeing those results in East Africa? Could it be that dolutegravir is just a weight neutral drug, and all what we've described before could all come down to the weight suppressive effects of two agents, efavirenz and TDF? Or is it that really dolutegravir has some, or integrase inhibitors in general, have some weight promoting effects? So looking a little bit at the evidence, and again, the scope of this presentation is to go over the studies we led, but obviously on this topic has seen a lot of clinical trials, a lot of clinical studies trying to understand this phenomenon and answer this phenomenon. But to summarize it briefly, there were some really strong signals that integrase inhibitors are causing weight gain. But really, there was a big question of how much of this weight gain is really confounded by the suppressive effects of efavirenz and TDF. Data from the AMPATH cohort, and again, this at the same time during the same cohort, other data were presented from Characterize and other studies that really showed the pre-switch NNRTI combo to play a key determining role in how much weight is being gained, and therefore underscoring the need for a separate study in order to separate what is weight gain caused by integrase inhibitor and what is weight gain caused by removing weight suppressive effects of efavirenz and TDF. Probably the biggest and the most well-known study on this topic was the advanced study from Africa that highlighted significantly higher weight gain with dolutegravir TAF compared to dolutegravir TDF, and the lowest with etripla, efavirenz TDF. But also around that time, a follow-up study looked at CYP2B6 polymorphisms and noticed that when we account for efavirenz metabolism, the amount of weight gain between dolutegravir and efavirenz is really no different, showing that basically it could all come down to the differences that were seen between efavirenz and dolutegravir to the weight suppressive effects of efavirenz. The other big question in this topic was the effect of tenofovir alafenamide, TAF. Multiple studies, including the one I just mentioned, showing a difference between TAF and TDF weight gain, showing that the weight gain with TAF is significantly higher than that with TDF. We knew already that TDF is weight suppressive. Now the question was, is TAF weight promoting? And again, because most of the regimens now are a combination of INSTI and TAF, how does that affect weight? But there were also some studies showing that maybe TAF is just weight neutral, because when patients were switched off of TAF, they did not lose weight. For example, in TANGO, when they switched to dolutegravir 3TC from a TAF-based regimen, taking the TAF off did not cause any weight loss. Similarly, in SOLAR, switching to cabotegravir rilpivirine was not associated with weight loss. The only time we ever saw weight loss when someone was switched off of TAF was in Characterize when they were switched to TDF. But this really did not, and this was only seen in women. But it didn't answer the question, is it because we stopped the TAF, or is it because we reintroduced TDF, which is weight suppressive? Additionally, in PrEP trials, while TAF and placebo were never compared head-to-head, we compared TAF and TDF, and then TDF and placebo, and it was noted that the weight gain with TAF and the weight gain with placebo are quite similar. So this again brought a separate question, just like integrase inhibitor. What's the effect of TAF on weight gain? Is it really a weight-promoting drug, or is it another weight-neutral medicine? This is all to provide the background of why did we decide to reevaluate the NA Accord analysis or cohort. So we wanted to define what are the next steps that will help us understand INSTI-TAF and weight gain. There were 4 questions that remained unanswered. 1 is, to what extent does INSTI-TAF associated weight gain really persist or even exist if we were to very rigorously account for the weight suppressive effect of efavirenz and the weight suppressive effect of TDF? Second is, do non-efavirenz and NNRTI also demonstrate a similar weight suppressive effect similar to efavirenz, or is it something that is only unique to efavirenz? Third, so in the initial NA Accord study and in the Vanderbilt cohort study, we saw some significant differences in integrase inhibitors. But here's the thing, in the original NA Accord analysis, most of the dolutegravir was co-formulated with abacavir, and most of the elvitegravir was co-formulated with TDF. Meanwhile, valtegravir patients had almost a similar prevalence of similar co-formulation of TDF and abacavir. So this brought up the question, could it really be that the original differences we noted between integrase inhibitors, could it all come down to this was a difference in the NRTI backbone? And could the NRTI backbone be this huge confounder that we overlooked in the original study? And then the last question we wanted to answer is, how much do race and sex influence weight gain, especially among patients receiving INSTI-TAF? Because we've noted in the original NA Cohort study, in the AMPATH study, it seems always that the weight gain with among women was significantly higher. So this prompted us to reevaluate the NA Cohort naive analysis cohort. And in this iteration of the study, we evaluated 32,000 patients enrolled in an NA Cohort over a much longer period of time, from 2007 to 2021. Again, comparing initial ART regimen through a linear mixed effect model that adjusted for a lot of baseline demographic and clinical characteristics. And here we wanted to do some sub-analysis. We wanted to isolate the effect of NRTIs, isolate the effect of efavirenz, look at how do individual integrase inhibitor drugs affect weight gain, stratified by different NRTI backbone, and stratified by sex and race. Presented those results in recent CROI, and the paper is currently under consideration for publication. But in this study, we had 32,000 patients, 84% males, 45% blacks, with a median age of 41, median baseline BMI of 25.4. And you can see the more patients we added over the later years, the higher is the baseline BMI, which again shows the growing epidemic of obesity among persons with HIV. Baseline CD4 count of 329. And again, this was 54, more than half of the patients who were ART naive, never received ART before, were either overweight or obese at baseline. Initial ART class, almost uniform, 41% NNRTI, vast majority of them were on efavirenz, 27% PI, and 32% integrase inhibitor. Unlike our older NA Cohort analysis, here we included more contemporary entities such as bictegravir. And when looking at the NRTI backbone, 72% were on tenofovir disoproxil, 12% on tenofovir alafenamide, and 12% on abacavir. And we really wanted in this analysis to account rigorously for NRTIs, because we know that the NRTI backbone is playing a key role in determining the extent of weight that is being gained. So, show you the results. This graph is again looking at all comers, everyone who was included, all 32,000 patients who were included in this cohort. So this was basically a replica of the original NA Cohort analysis. Again, showing very similar weight gain between INSTI and PI, but much lower weight gain with NNRTI. So the INSTIs would include bictegravir, dolutegravir, raltegravir, all the different INSTIs, and also would include all the different NRTI backbones. But this really doesn't answer any of our questions, because what we needed to know is, could the green, the NNRTI, be much lower, all be driven by the fact that efavirenz suppresses weight and tenofovir disoproxil suppresses weight? So to answer that, we did a stratified analysis where we only included those who are on TDF FTC, so therefore removing the effect of the NRTI backbone. And from the NRTI group, we excluded efavirenz. What we noted is really the weight gain with the non-efavirenz and NRTI is still much lower than integrase inhibitor and PI. And therefore, no, we cannot say that all the differences are due to efavirenz and TDF being weight suppressive. Because when we had everyone on TDF and we excluded the efavirenz, there was still a significant difference in the amount of weight that's being gained between INSTI-PI and NNRTI. So this really raises the question, well, while we can now say that all this all cannot be explained by efavirenz and TDF, but then the follow-up question is, well, is it that INSTIs and PIs are causing more weight gain, or is it that this is a group effect of NNRTIs and all NNRTIs are suppressing weight? The second thing from the original NA cohort analysis was the differences between integrase inhibitors, between INSTI core drugs. So the red line here is bictegravir, the green is dolutegravir, blue is raltegravir, and the purple is elvitegravir. If you were to look at the first graph, so those again, all comers, not accounting for the background NRTI, you would notice some significant differences in the amount of weight that is being gained. But again, I would remind you that those had very different NRTI backbones. And therefore, to account for that, we stratified the analysis by whether the backbone was TDF-FTC or whether the backbone was TAF-FTC. For the upper graph with the TDF-FTC, you notice that the weight gain with elvitegravir is significantly lower than that of dolutegravir. And in the lower graph, also weight gain with elvitegravir is significantly lower than bictegravir or dolutegravir. So this really answered the key question. Because originally we couldn't tell whether the differences between INSTI core drugs all comes down to differences in the NRTI backbone. And it turns out that no, there is something particular about elvitegravir, because when we account for the NRTI backbone, we're still seeing some significant differences in the amount of weight that is gained, with elvitegravir being significantly lower. The last question that we wanted to answer is the effect of sex and race. And here we took dolutegravir, bictegravir, and TAF. So patients who started on dolutegravir or bictegravir and TAF, and looked at the weight gain by sex and race. Very similar to prior results, you notice that the weight gain among Black females is significantly higher than any other group. So that INSTI and INSTI-TAF combination is associated with significantly higher weight gain compared to other combinations. But there are certain groups, particularly Black females, who are experiencing the most amount of weight gain. And this is a difference by more than 3 kilos compared to, for example, non-Black females. So with this updated NA cohort, what did we learn? First, we learned that there are class-specific variations. There's lower weight gain with NNRTI compared to INSTI and PI. And no, this cannot be explained by efavirenz alone. This cannot be explained by TDF alone. But one question we could not answer is whether non-efavirenz NNRTI could also be weight suppressive. The second thing we learned that yes, there are INSTI drug-specific variations, with particularly lower weight gain with elvitegravir, and that cannot be explained by differences in an RTI backbone. The last thing we also learned is that there is a disproportionate impact in this weight gain, especially with INSTI-TAF, and we're focusing on INSTI-TAF because this is where most of the contemporary regimens are based on, particularly among Black women who are experiencing the most amount of weight gain and likely experiencing significant metabolic complications from this weight gain. So ending this presentation on one last study from NA cohort that we're currently finalizing is switch analysis. So I just presented to you the naive analysis, but as you probably all know, there's been a large drive to switch patients off efavirenz TDF into INSTI-TAF. We just talked about how INSTI-TAF is associated with significantly higher weight gain among treatment-naive individuals. So we wanted to see what's going on in the US and in Canada when a large-scale push of INSTI-TAF is happening and switching patients off of efavirenz TDF. So in this analysis, to be included in the analysis, patients should have been originally included in the treatment-naive analysis. So therefore, they started their treatment within NA cohort. They got NNRTI for at least 2 years, They achieved viral suppression and remained virally suppressed until they switched to integrase inhibitor. They needed to have at least one weight gain after switching to one weight measurement after switching to integrase inhibitors. And we again did a mixed effect model to understand how the rate of weight gain is changing. Primary analysis included everyone who switched from NNRTI to INSTI, while the secondary analysis focused particularly among those who switched from etripla, efavirenz TDF FTC, to INSTI-TAF. So here, 3,000 patients. So we had started with 10,000 treatment naive, 3,000 met our criteria, 19 cohorts across the US and Canada, 90% of them males, 43% Black, median age of 43 years, and a median BMI of 25. As you can imagine, most of those patients switched from an efavirenz-based regimen. Particularly, they switched from efavirenz TDF FTC. What did they switch to? They switched to all different types of integrase inhibitors. Around 24% switched to bictegravir TAF FTC, 37% to dolutegravir. Those who switched to dolutegravir, as you can imagine, most of them were Trimec for abacavir 3TC based. 35% switched to albitegravir, and those were broken almost evenly between Stribal and Genvoya. And a small percentage were switched to raltegravir. So when we looked at everyone who started with an NNRTI and switched to an INSTI, regardless of their NRTI backbone, we noticed that very similar to what we saw in East Africa, the pre-switch rate of weight gain, 0.6 kilo per year, higher than what we saw in East Africa in terms of increase in the rate of weight gain, increased from 0.6 to 1.7, with estimated weight gain of 3.3 kilos in 2 years. So again, those are virally suppressed patients, stable patients. The only thing that's happening is they're switching their ART, and within 2 years, they're gaining 3.3 kilograms. When we focused on those who switched off of etripla and switched to an INSTI-TAF-based regimen, you notice that the weight gain is significantly higher. So the rate of weight gain went from 0.5 to 2.2 kilos per year to 2.2 kilo per year, with an estimated weight gain by year 2 of 4.4 kilos. This will have a huge clinical implications. Almost all of the patients across the US have switched off of efavirenz TDF. The preferred regimen has been INSTI and TAF. And with a 4.4 kilo average weight gain over a 2-year period, you would imagine a large proportion of those patients suffering from metabolic complications from this weight gain, which we hope we would explore a little bit further in future studies. So with that, that brings me to the last study that I wanted to discuss on this topic. But before I end it, I really want to acknowledge very key people who have been key for completing all of those studies, particularly John Curta and Peter Ribeiro. They've been incredibly helpful, supporting mentors from the very, very first study that I started on this topic. Really want to thank the Epi Outcomes group and Dr. Sterling and Megan Turner with the very original CCC cohort study, the Tennessee CFAR in general and Dr. Haas, the NA Accord group, the large group of AMPATH, IU. They had been key players in helping complete all the AMPATH switch and naive studies. Incredibly grateful to the team here at Nashville Cares for all their support for the past year, and also for Gilead Sciences for funding 3 of those studies through HIV Scholars Program, as well as investigator-sponsored research.